EMG question of the day. How would you label this activity? A. Regular, B. Semi-regular, C. Irregular, D. Bursting. Since voluntary and different type of spontaneous motor activities recorded during EMG produce morphologically identical waveforms, we must look at firing patterns to help identify them. But I must warn you that there is no firing pattern present in a specific EMG activity that cannot be found in another, except when we encounter an EMG spontaneous group activity with discharges over 150 Hz, which by definition is called neuromyotonia, when a group discharge occurring with perfect superimposition, as you can see in this frame, which is characteristic of complex repetitive discharges, or if we encounter a waxing and waning pattern, a term that we will be explaining later on during this talk, and is typical for myotonic dystrophy. Yet other than for the three just mentioned situations, neuromyotonia, complex repetitive discharge, and myotonic dystrophy, the lack of discharge pattern specificity for all other spontaneous activity should not stop us from associating specific firing patterns with the most likely spontaneous activity. A good place to start is to consider three general types of firing patterns: regular, semi-regular, and irregular. So let's talk about regular discharge. Regular discharges in the EMG lingo are divided into those with no change or less than 1% change in the duration of the interspike intervals, as illustrated here, the vertical lines corresponding to the discharges or potentials, the horizontal lines to the intervals. This pattern of discharge is typical of complex repetitive discharge. Complex repetitive discharges, as you can see in this frame, the interpotential intervals here and here are the same. This is the reason for the perfect superimposition of this type of spontaneous activity, as we mentioned earlier. In addition to complex repetitive discharges in this group, we also have fibrillation. Fibrillations do not usually have this firing pattern, but as you can see in this frame, sometimes they do. This run of fibrillations is from an elegant study using diaphragmatic denervated muscle fibers from rats. Interestingly enough, this study also lists among regular fibrillations pair fibrillations, to which the author refers to as doublets, triad, to which we refer as triplets, and bursts of fibrillation with relatively regular interpotential intervals within the burst and relatively regular interburst intervals. The cause of all types of regular fibrillations with no change in interspike intervals is muscle fiber membrane instability. Next, we have regular discharges with a linear change in interspike interval, as illustrated here. This type of discharges are characterized by a linear increase or decrease duration between subsequent potentials. An example of linear decreasing frequency pattern is the one we encounter with most fibrillation potential, which as regular fibrillations with no change in interspike intervals result from unstable muscle fiber membranes. In this panel, you can see an example of regular discharging fibrillation with linear increase interpotential interval. The initial interpotential interval falls short by the middle of the panel and more so at the end of the panel. This drop in frequency will become more pronounced as the fibrillation runs comes to an end. The third category of regular discharges corresponds to regular discharges with exponential change in the interspike intervals, as illustrated here. This type of discharges are characterized by a relative exponential increase or decrease in duration of interpotential intervals. This pattern is often referred to as waxing when the frequency is increasing, thus the interpeak intervals duration decreasing, and waning when the frequency is decreasing, thus when the interpotential intervals duration is increasing. These terms are also used for similar changes in amplitude: waxes for increasing and waning for decreasing amplitude. I will show you three examples in the next few minutes that help understand these terms in relation to frequency and amplitude. The first example illustrates concordance between the terms for frequency and amplitude. Notice that initially the frequency is about 50 Hz and by the end of the activity 20 Hz. So the frequency is waning and so is the amplitude. The amplitude of the first potential is about 160 microvolts and the amplitude of the last potential is 50 microvolts. Now let's look at the second example. In this example you can see a waxing frequency because the frequency is increasing and a waning in amplitude. Notice that the initial, mid and end interspike intervals become significantly shorter, hence frequency wise the activity is waxing, but in amplitude waning. Notice that the amplitude in the first potential is rather tall, whereas the last potential is short. Now let's look at the third example. In this example, we find waxing and waning in the same activity. Waxing in frequency and amplitude, followed by waning in frequency and amplitude. This is typical of myotonic dystrophy. As we previously mentioned, this is one of the three discharge patterns with specificity. So exponential changes in both directions is pathognomonic of myotonic discharges. There is also a rare type of fibrillation that presents in a similar fashion. This type of fibrillation is characterized by exponential increased interspike intervals, as you can see here, and irregular interburst interval, as you can see in this frame. The sudden appearance of the potentials with a sustained amplitude gives a bursting quality to this type of fibrillations. This type of fibrillation was given the tentative and unfortunate name of myochemic fibrillations, although not associated with clinical myochemia. So we have talked about regular discharges. Now let's talk about semi-regular discharges. Semi-regular discharges can involve solitary potentials, as is the case of voluntary motor unit action potentials, also referred to as operational motor unit action potentials, motor unit action potentials, or motor action potentials. Semi-regular discharges are also seen in group potential, as is the case of the interburst intervals of some myochemic discharges and the interpotential intervals of neuromyotonic discharges. So let's first look at voluntary motor unit action potential, here referring to the motor unit's action potential brought about by minimum voluntary contraction. As you can see in this frame, voluntary triggered motor unit action potential discharge in a semi-regular fashion. As expressed here, the difference between the first and the second potential is about 13%, as it is between the second and the third, 23% between the third and the fourth, and 28% between the fourth and the fifth. In Preston and Shapiro's book, there is no time specification to separate semi-regular discharging pattern from regular or irregular discharging pattern, and these potentials are used as the prototype of semi-rhythmic activity in this book. Other limits the label of semi-rhythmic to a rhythm with an interpotential intervals randomly varying between 1 and 10%. Now let's go back and look at semi-regular group potentials, which, as we previously mentioned, includes myochemic and neuromyotonic discharges. Semi-regular discharge patterns occur sometimes in the case of myochemic discharges between bursts, as you can see in this frame. There is a slight variability in the duration of the interburst in myochemic activity. The second interval is shorter than the first, and the third one is about the same as the second. Notice that the horizontal lines length are all similar, corresponding to the first interburst interval. Semi-regular discharges are also present in neuromyotonic dystrophy. Here, the semi-regularity is present in the interpotential intervals, as you can see in this frame. Amplitude-wise, neuromyotonic discharges at times have a linear and more often an exponential drop. Finally, we come to potentials that discharge irregularly. Irregular discharges are characterized by potentials recurring at random. Irregular discharging patterns are more often seen in 4 conditions. The first condition I will mention is end plate potential. Irregular discharge pattern is characteristic of end plate potential. Notice that the interpotential duration variability present in this frame. It is important to stress that here we are referring to the potential allegedly brought about by damage to the terminal axon by the EMG needle. This activity, according to some authors, appears to be the result of the summation of miniature end plate potentials sufficient in number to produce a spike, but insufficient to generate a propagated muscle action potential. I have great difficulty visualizing such an event because once the voltage increases sufficiently to produce an end plate spike, the odds are that the end plate action potential will propagate to the rest of the muscle fiber. Anyway, end plate potentials tend to taper off if the needle is not moved, but usually the needle is rapidly withdrawn because it causes pain, so we do not get to see the tapering of the potentials. The second condition we will mention in this group is myochemic discharges. We have already referred to the interburst interval present in myochemic discharges when we talked about semi-rhythmic discharges. Yet, just as often, the interburst interval in myochemic discharges is irregular, as you can see here. Notice that this was recorded at 1 second per division. Thus, multiple potentials are lumped together, giving the appearance of a single event. It is important to notice that interpotential interval or intraburst potentials in myochemic discharges also have an irregular discharging pattern. The third condition is fasciculation. Notice that judging by the size of the potentials, we are looking at probably 4 potentials brought about by 4 different motor neurons. In this frame, I have indicated the different potential using different color arrows. Now notice the interval between the potentials indicated by the yellow arrows. This interval lasts for about 7 seconds. Also notice that no similar potentials are present for about the next 11 seconds. This finding is consistent with irregular discharge pattern. The fourth activity that I will show you in this group is fibrillation. Fibrillations can be very irregular, as you can see in this frame. Most authors report that 10% of fibrillation encountered in clinical practice is of this type. Others report an even larger number. This run of irregular fibrillation is from the same study we saw before. As you recall, it was conducted using diaphragmatic denervated muscle fibers from rats. These authors determined that irregular fibrillations have different origin than regular fibrillations. While regular fibrillations originate from oscillation of the muscle fiber membrane potential as a whole, irregular fibrillations arouse from discrete depolarization, to which they refer to as fibrillatory orient potentials. Fibrillatory orient potentials are generated at the T tubuli. Hence, while the tubulation abolishes irregular fibrillations, it does not abolish regular fibrillations. Another interesting feature of irregular fibrillation is that they appeared later than regular fibrillations in denervated muscles. So the answer to this question is C. Thank you very much for your attention.